were actually operative. 30 of them were actually mild traumatic brain injury, which needed no treatment. And epidural hematoma, acute subdural hematoma, and gunshot wounds were the ones. There was no morbidity or mortality reported in that 1 year incidence in PGH. Okay, so there. So what do we do? Okay, so if you look at this, slide, okay, so there's lots of things to do and a lot of areas where we can make a difference. Okay, so hypersmolar therapy, decompressive craniectomy, cerebral perfusion pressure, etc. So a lot of things. No, so ICP threshold, neuroimaging, neuromonitoring, lots of things you can work on. But I want to take it all out and what do we need to work on? And I think quite distressing as anesthesiologists, we are mainly concerned about short-term outcome. And what do I mean by that? Is as long as we extubate the patient, gising siya, we're happy. Okay, so that's good, and we don't want anyone to die in the operating room. Having said that, I think we should involve ourselves more in the hospital and administration in order to impact long-term outcome. And long-term outcome means the long-term neurologic function and the Glasgow outcome score. So outcome, aside from outcome, the guidelines will also tackle ICP control and seizure prevention. Okay. So the next slide, I'm going to go through the guidelines quickly, okay, and just very quickly, the level of evidence they used, okay. So for the levels of evidence, 1, 2, and 3, level 1 means based on high quality research where the treatment, any additional research is not likely to change the treatment effect or the estimate of the effect of the research. Level 2, it can change, and level 3 are very poor studies. And let me tell you, pediatric research is very, very, very difficult for 3 main reasons. First of all, the incidence of disease in pediatric is much less. Number 2, you get patients who have different, a pediatric patient is not an adult patient, so there are different results, or sorry, different, what do I want to say? Different results as compared to adults. Okay, let me just stick with results. And lastly, consent issues. They are not able to give their own consent. Usually the family has to decide. So for all these 3 reasons, evidence in pediatrics is low. So having said that, let me make it very simple for us to divide all of these guidelines into 3 main topics. What not to do, what to do, and what others should do. So what should we not do? This is the easiest thing, diba? So when you get a patient who is a pediatric brain injured patient, what should we not do? Number 1, okay, so you can see this. This is a normal intra-op thing. As you can see, the end-tidal CO2 is 25. That's very low, okay? So do not ever, ever, ever hyperventilate the patient. Especially in the first 48 hours, do not. So maintain normocapnia from 35 to 45, okay? So, so that is the thing that, so that is bawal yan, okay? So it is level 3 evidence in pediatrics. So prophylactic severe hyperventilation should not be done in the first 48 hours. If you do hyperventilate, you can do that. I'll talk about that later. You can use it to manage refractory ICP. So if the ICP is very, very high, if you have ICP monitoring, you can use it. But if you hyperventilate, you do not suddenly stop hyperventilation because there may be rebound increase in intracranial pressure, okay? And then, so why does that happen? We all know that decreased PaCO2 will decrease the ICP and cerebral perfusion pressure, okay? So these are all good because it will bring down the brain. Having said that, very, very elegantly seen in one of the studies is cerebral oxygenation will actually also decrease with a decreased PaCO2. And this will also decrease cerebral blood flow. So decreased PaCO2 due to hyperventilation, even though the ICP goes down, you have decreased cerebral blood flow, which is bad for outcomes. So for adults, it's the same. Having said that, it's level 2 in adults because of better quality studies rather than level 3. Next, so do not hyperventilate. Number two, temperature control or hypothermia. Do not give prophylactic moderate hypothermia. So 32 to 33 degrees, it is not recommended to improve overall outcomes, okay? So this is not used for brain injury in order to improve outcomes. Having said that, you can use hypothermia for refractory increases in ICP. If you do institute hypothermia, you have to rewarm 0.5 to 1 centigrade every 12 to 24 hours. If you're using phenytoin for seizure prophylaxis, you have to monitor the levels, okay? ICP rebounds during rewarming, and then there. So for adults, these adult guidelines are not applicable to children, okay? So in adults, they are more aggressive in terms of hypothermia. And number three, what you should not do is corticosteroids. So yung mahilig mag-Dexa, methylprednisolone, then the use of corticosteroids is not suggested to improve outcome or reduce ICP. So do not use steroids in traumatic brain injury. But however, this guideline is not circumvented to replace, or not intended to replace those who need steroids, like suppression of HPA axis or on chronic steroid therapy. Having said that, in adults, steroid use or not using steroid is level 1 evidence. So to reiterate, no hyperventilation, no steroids, and no hypothermia. I think my voice is so loud, I think they toned down the mic. Yeah, so I don't think I need a mic. So anyway, next. Okay, so what should we do? Okay, so this is what we do. First, advanced neuromonitoring. So these are the things we can do. Dr. Mariano mentioned NIRS. NIRS is a non-invasive spectrophotometric technique in order to get the tissue oxygenation of the brain. So it's not been validated in terms of accuracy as compared to invasive monitoring, where we use the light Cox or the neurotrend, which has gone outside, in order to get tissue brain oxygenation. So should we use advanced neuromonitoring or getting tissue brain oxygenation? There is insufficient evidence for the use of this. However, if you're using it, you keep the tissue brain oxygen monitor above 10 millimeters mercury. Normal values are 20 to 30, but keep it above 10. It shouldn't go below 10 for better outcomes. This is level 3 evidence. So adults, no recommendations in terms of neuromonitoring. So we can take that out, okay? We don't need brain tissue oxygenation, okay? Next. Oh, sorry, that's still what not to do, okay? So yung what not to do. So what to do? Number 2, ICP monitoring. So there's level 3 evidence for use of ICP monitoring. So what are the questions we want to ask? Are the children with severe TBI or traumatic brain injury at risk for intracranial hypertension? Yes, patients with severe TBI, 50% of pediatric patients will have intracranial hypertension. Is this data useful in managing pediatric patients? Yes, it is. And does ICP monitoring improve outcomes? Yes. Having said that, what is the problem with ICP monitoring? Since the patients are monitored very well and we can see the ICP trends, these patients in which ICP monitoring is done will actually have a greater ICU stay and more treatment being done to them. In fact, one study shows that there's a higher risk of ventilator-associated pneumonia or sepsis because of the longer ICU stay. But in terms of final outcomes, it tends to equalize. So they're overtreated because there's more things to treat. So it's like you, if you're you're doing a scoliosis surgery patient and you have an A-line versus NIBP. If you're NIBP, okay, it's good, the BP. But if you're A-line, beat per beat, oh no, it's 70, 60, and then you're going. And then with an NIBP, it's 110, it goes down 60, then it goes up again. So again, they may tend to overtreat, but outcomes are the same. So what value is necessary? I wanted to recognize this, and this is the next part of the guideline. 20 is the value. What is 20? Keep ICP below 20. Okay, all of these studies, another caveat, are done in adult patients. So in pediatric patients, they have a lower ICP. For children, it's 5 to 10. For adults, it's 10 to 15. And in infants, it's 1 to 6. That's the ICP. So this 20 number is actually based on adults. Again, no good studies on pediatrics. So this is a level 3 evidence in terms of keeping the ICP below 20 when you are treating this pediatric traumatic brain injury. Okay, so a lower threshold may be appropriate for pediatric patients. Okay, so there. Now, what is the CPP threshold? As Dr. Mariano mentioned, CPP is MAP minus ICP. The laptop is very slow. Okay, it can't keep up with my, yeah. Okay, so CPP, MAP minus ICP. Okay, so what is the minimum for pediatric brain injury? As I said, you have a lower ICP and also lower MAP in general because you have a lower blood pressure. So the minimum is 40 millimeters mercury, maintained between 40 to 50 millimeters mercury. Okay, and